Alright, so now we're going to finish up the skeletal system by going over articulations, also known as joints. It's the third outline in the third module under skeletal. And for articulations, I cannot stress this enough, for your exam, you have to be able to classify the same joint or same articulation two different ways. One is based upon structure, one is based upon function. Function means range of motion, okay? So, if you go to your outline that I already put out to you, I already talked about what an articulation is, or a joint. It's just where two bones come and meet. Now, when I go through these, I'm going to go through them again because you can read this as well as I can. I'm just going to go over the major points. The major things you want to look at is going to be the space between the two bones, the collagen fibers that connect them. If the collagen fibers between two separate bones are very short and very tight, that means you're not designed to move very much. The longer the collagen fibers are, that gives you a little more motion, and then eventually longer collagen fibers, even more motion. Okay, so what's going to dictate kind of the range of motion is going to be the space between the two bones and the length of the collagen connecting the two bones. Okay, so if you look on your outline, again, the bones can be classified structurally one way, functionally another. When I wrote my outline, basically I wrote it that you'll see in the outline that it says if you have this structure, then you should be classifying this as this function. Because if you remember from day one, I told you in anatomy and physiology, structure dictates function. So you're shaped this way, so you can or can't do this. All right, so first one you see under structural is called a synostosis. Syn means same. Osto means bone, meaning it's now the same bone. This is not going to appear anywhere in your examination, meaning that if whenever you go, say you're going to be studying for physical therapy or something along those lines, you're going to take a class called kinesiology to do that. You're going to need to know these terms, which is what I'm going over with you right now. Synostosis means that you don't have, basically, these were bones which were separate when you were inside your mom. Okay, when you were a fetal form, meaning inside mom they were separate bones. However, as you matured, as you developed inside mom, eventually they fused to become one bone. And so therefore now as an adult, it's synostosis, it's one bone. This is why this is not going to be on your examination, because as an adult it's one bone. All right, so don't worry about classifying these. I'm just going them over with you. Examples of synostosis. Your mandible, your jaw, is a synostosis joint right here. Why? Whenever you were inside mommy, whenever you were an embryo, you had gills. This was gill arch number 1. This was gill arch number 2. They fused to make your mandible. If you didn't have gills, you wouldn't have a mandible. Where they fuse, you call your chin. So therefore, understand whenever you're inside mommy, these were two separate bones. They fused to make one bone, your mandible. Your hip, your coxa, was the ilium, the ischium, and the pubic bone. However, those were three separate bones. However, as you matured, they fused to make one coxa, one hip. Your sacrum, on your back part, was 5 separate bones. When you matured, it becomes one. Your coccyx, your tailbone, was 4 separate bones fused to make one. Hopefully I made my point clear. All right, so basically with that, you're not going to need to, again, classify this on examination. It's going to be more for your information. Now, follow, that means then if we talk about it in terms of function, it's called a synostosis, meaning same bone. Let's move on to things you're going to be more liable for, all right? So the next three you notice for structural classification are fibrous, cartilaginous, and synovial. This now is going to deal with the how close the bones are and the collagen connecting them, okay? So, fibrous. Fibrous means that they're basically going to be real close together and short collagen fibers. If we're going to classify these functionally, that means you're not going to have any motion or very minimal motion. If you pop down, that is called a synarthrotic joint. Notice, syn, same, arthro, joint, same joint. These joints are designed for basically absolutely no motion or very tiny motion. Examples you'll see when we go through it are going to be the sutures that are in your skull. They're going to be the gomphoses, which are your tooth sockets. And then we're going to have syndesmoses, kind of like rib number 1 coming into your manubrium. It's not designed to move because otherwise you would dislocate your torso from your spine. That wouldn't be, favored. So then we go to cartilaginous. Cartilaginous, now the collagen fibers are getting a little longer, which means now we get so-so motion. Not woohoo, whippy, yay motion, little tiny motion, meaning we can slide past each other a little more, okay? So underneath classification, you notice for functional, that is called amphiarthrotic. Amphiarthrotic means so-so motion. So synarthrotic means no motion. Amphiarthrotic means so-so motion. Now we go to the one that if you have like a 7th grade health class taught by a gym teacher somewhere in your past, this is probably the one you went over. Structurally, it's called synovial. Synovial means now there's going to be a large gap between 2 bones. There's going to be synovial fluid in the joint, which is a lubricant and also nourishing and removes waste. Along with that, you can have other bells and whistles in there called a bursae, called your menisci. Usually those bells and whistles are areas designed more for joints which are put under more pressure. Most famous one obviously is going to be your knee, then also your elbow. Those are going to be the 2 ones for that. But synovial joints means that now we're going to have a bigger gap, which means we're going to have a ton of motion. If we classify that functionally, that when you look at it is called diarthrotic. Diarthrotic means big motion. That's like me moving my hands right now, wiggling my finger, moving my elbow, rolling my shoulder. All of those are big motions, okay? The only way to do that is to have a gap, longer collagen fibers, and then have a fluid for lubrication to be able to do that. Good? So, the 4 types structurally are a synostosis, and therefore it's the same bone. Don't worry about that one functionally. The 3 you're liable for are going to be, fibrous, also that's functional, also known as synarthrotic. Synarthrotic means same joint. Okay? Next one is going to be cartilaginous. That's functional, also known as functionally amphiarthrotic. So-so motion. Last one then is going to be synovial, functional classification, which then correlates to diarthrotic. Diarthrotic means big, wide motion. Good? All right. Now, the rest of this talk now is going to be going specifically then with the 3 types of joints you're going to be liable for, meaning the synarthrotic, diarthrotic, and amphiarthrotic. All right. So if we go down in your outline, next thing up you see is synarthrotic, quote, immovable joints. There is a slight motion in some cases. First one you see there, a perfect example of synarthrotic, like I said, in your skull, are your sutures. Now, picture the skull in your imagination. If you remember, there were sutures that had little squiggly lines on them, like a snake. That's one type of suture called serrate. Think of it kind of like a steak knife edge. We're going to have one serrate area and another serrate area, and they come together and they interlock, meaning the collagen fibers are real short, which means there's no way in hell you're moving these. Okay? So examples of sutures you already know occur within your skull. Also, keep in mind that that's the major one. So for sutures, there's going to be 3 types of suture lines as I started to talk about. Number 1 was serrate, which means wavy. The second one is going to be called, brain fart. Second one is called butt. Butt means, think of it kind of like you're putting out a back porch on your house and you have 2 2x4s and they're lying tip to tip. It means they don't overlap. And therefore, they're basically just touching each other side and face to face. Where would you see that? Where your palatine bone meets your palatine process in the upper part of the roof of your mouth. If you remember, the maxilla going back to your hard palate is the palatine process, and there's that little tiny crack, and then there's the palatine bone. That's a butt joint, meaning that they don't overlap. The last one, I'm losing my track here. So that's the butt one. Next one is going to be the lap. Lap is, here, best if I draw it. Lap is this. You're going to have one bone come out, and it's going to be beveled, and therefore another bone is going to slide underneath it. So therefore, it's kind of like furniture where you have tongue and groove. So therefore, butt would be like this, where they're like 2 boards coming into one another. Serrate would be a squiggly line where one bone and another bone kind of interlock, almost like, you know, the teeth on a zipper almost. Okay? Good? All right. Now, the next one underneath synarthrotic, would mean the same one, is going to be a gomphosis. Gomphosis, real simple, go brain dead. If you see gomphosis, anything dealing with your tooth socket, that's a gomphosis. Think, when you chew, do your teeth move? Yes, they have to move. Very slightly, because if they didn't move, every time you chewed down, think on something hard, there'd be no give and no play, and your teeth would break continually. Therefore, by having a little give, it gives off a little of the pressure. Now, should your teeth be free range moving? No. You go to a dentist, go to a periodontist, because you got an issue now. Now, that means anything dealing with a tooth. Think, when you go to get a tooth extracted, you don't go to a dentist. All that person does is clean your teeth, take your x-rays, maybe do some fillings. To get a tooth extracted, you have to go to a specialist called an oral surgeon, known as a periodontist. So when you hear the word or see the word periodontal, that means of the tooth, okay, going to the tooth. The reason why you have to go to an oral surgeon is because if a dentist just yanks your tooth out, you got to understand there's periodontal nerves and blood vessels going to it. If they do it incorrectly and crack it, if the tooth is infected, the bacteria can go into the periodontal blood vessels and basically kill you. Basically, it can cause sepsis and travel through your bloodstream. If the person extracts the tooth incorrectly and they destroy the periodontal nerve, you're going to lose feeling on that side of your face. That's why you go to a specialist. You don't have a numb net or tie your string to your tooth and close a door. Okay, but, you know, if you follow Three Stooges, that's a common thing. All right, so next one is called a synchondrosis. Synchondrosis means, notice the word chondro, cartilage, same cartilage. So synchondrosis is going to be where we're going to have two bones connected with hyaline cartilage. Hyaline cartilage, you remember, is not super flexible, nor is it super hard. The two major ones you're liable for, understand, like I said, is going to be where rib number 1 comes into your manubrium. This is not designed to move. It's holding, literally that joint is holding your chest to your spine. That does not come apart. So that's a no-fly zone there. Another one that would be considered to be a synchondrosis. Synchondrosis. When you're still growing, as you know, your growth plates in your long bones, you have your diaphysis, the epiphyseal plate, and then you're going to have the epiphysis. While you still have cartilage there, that's a joint because the bones aren't connected yet. There's cartilage in between them. That's an immovable joint. Eventually, as you know, that cartilage plate gets used up and it becomes one bone, which would be a synostosis then. So basically then, if you still had an epiphyseal plate, that would be an example of a synchondrosis. Moving on now to the so-so moving joints, which would be called, amphiarthrotic, slightly movable. All right, so you see in your list, I give you two, syndesmoses and a symphysis. Symphyses we talked about already. That one you already know. You already know the pubic symphysis, holding your pelvic girdle together in the middle. You do understand a woman has to give childbirth. You get that, right? In order for a baby to slide down and to be born, her hips cannot be rigid. Whenever she's nearing childbirth, or actually during childbirth, she's going to give off a hormone called relaxin. Relaxin actually takes the pubic symphysis and makes the joint flexible. So therefore, her hips will actually be able to open up wider to facilitate the baby's drop, then for effacement, and then push the little guy or girl out. Okay? Without that, you need surgery. It's just that's all. There's nothing else you can do about it. Now that's a symphysis. Let's see. Other types of symphyses. Keep in mind too. Let's see. In between your vertebral discs, you have in between your vertebrae, the vertebral discs. Understand that's how you're able to move your back up, twist, do all sorts of things because there's a cartilage plate in between them. If you get a slip disc, now you got bone on bone, which means you lose flexibility. That disc is an example of a syndesmosis. Your back's allowed to move, but you can't, like your arm go wee back and it just goes everywhere. You can't do that. All right. Now, a syndesmosis. Syndesmosis, if you look in the outline, cannot stress this enough. Huge, goddamn, ginormous stars on this. If the description says, from my notes, if you have longer collagen fibers that run the length of two bones, no brainer. That's a syndesmosis. Where would you see that? You already know you have your ulna, you have your radius. You have two bones that run this way. Well, there's going to be collagen fibers that run the length. That's a syndesmosis. Between your tibia and your fibula, again, they run and there's a parallel, and therefore they're going to have collagen fibers that run the length of those two. Let's see. Good enough. Let's move on then to diarthrotic. Now, diarthrotic means that we got big motion, okay? So, with that, I'll come back to my really crappy drawing board here. All right, so let's see if I can do this upside down. This is the bottom end of your femur, okay? Then you're going to have the top part of your tibia. All right? Your kneecap would be sitting out in front of here like this, okay? So that would be my leg facing you, all right? Now follow. This is going to be an example of a wide-range diarthrotic joint, okay? A synovial joint functionally. To do that, I'm going to have two capsules. I'm going to have, if you remember studying the bones, there is the medial and lateral epicondyles. What are those for? They're going to be for ligaments to come from the tibia to the femur and back and forth, basically holding them in alignment. So when a knee goes out of joint, that means that they came apart. That's a no good either. That's you're going to be off your feet for a while. Now understand there's an outside capsule. So if you notice in the notes, let me make sure I follow my notes correctly. You're going to have an outer fibrous capsule that's going to have these ligaments to it. But then then we have this internal capsule. This internal capsule is now going to have tissue come in from both sides, and there's going to be a little fluid-filled chamber in the middle. That's the synovial capsule. That's the synovial fluid. Now, if you ever heard somebody go, I hurt my knee, I got water on my knee. That's synovial fluid that has leaked out and basically causing edema, which then means you can't move the joint anymore until the swelling goes down. All right? Now, for that, then, let's see, I already went over that. Now, extra bells and whistles that I put with diarthrotic. I can't stress this enough, big star. Number one is a bursae, B-U-R-S-A-E. Bursae basically is going to be a fluid-filled chamber like this. What's it filled with? Synovial fluid. What does it do? If I have a muscle like this coming down, it's going to take the tendon from the muscle and pre-stretch it until I hit the bone that I need to. Okay? Well, why would you do that? Imagine you have a wagon and it's filled with bricks. Okay? Tied to the handle, you have a bungee cord tied to the handle. The only way to move the bucket, the wagon of bricks, is to pull the bungee cord. Well, think. If you grab the bungee cord and start moving, the bungee cord's going to stretch. Does the wagon move? No, because the bungee cord has to stretch to a certain intensity till eventually you get the force to move the wagon, correct? Well, what does a bursa do? A bursa pre-stretches the bungee cord so that whenever you go to pull on it, you don't have to wait. The force is instant, and therefore it moves. It helps to redirect and augment the force, okay? Also provides a cushion, blood vessels, and things can go underneath it, but, that's the major part of it, okay? The second one you see there are going to be menisci, M-E-N-I-S-C-I, or meniscus for one. If you remember back when we went over the histology, we went over fiber cartilage. Fiber cartilage, I told you, is all found in your knee. In your knee, you're going to have a C-shaped disc going this way and a C-shaped disc coming this way. So therefore, your femur's here, your tibia's here, and these two discs sit in between. They're C's, leaving a fluid-filled chamber in it. Those C-shaped discs are your menisci. What are they? They're made of fiber cartilage. If you remember, those are shock absorbers. So every time you push on them, you don't have your tibia and femur going boom, boom, boom on each other. Because if that does, you are now poster child for a knee replacement eventually in your life. Okay? And also remember, too, that fiber cartilage is avascular, meaning that if you destroy it, if you tear it, it can't grow back. You need arthroscopic surgery to kind of knit it back together again and pray that it holds. All right, so with that then, to tie this all with one big ribbon here, is then there's going to be 6 major diarthrotic joints you're going to have to know. And know the examples. Now follow this, everybody. The examples I gave you in your outline, the way I explained them to you in your outline, there's a reason why I did it, okay? Know it the way I present it to you. Do we make myself clear? Now, so with that, first one you see there is a sliding gliding joint. Real simple. That's you going bye-bye, or if you want to be the queen, bye-bye. Okay, whatever you want to do. Those are going to be your carpals. Those are your tarsals, where they're going to be sliding past one another one way. So that's a monoaxial movement. I can move it this way, or I can move it this way. I can't do both at the same time. If you ever try to do that, you can't go, doesn't work that way. You got to do one, then the next. Those are sliding, okay? So those are designed basically for your flat bones in your wrist or in your ankle to therefore slide past one another. All right, so therefore you get backward plane movement. Next. We have hinge joint. Hinge joint's easy. That's your elbow. That's kind of like your knee. That's this. Okay, so a monoaxial motion. So notice that would then be you have your trochlear notch on your ulna going around the trochlea of your humerus. The humerus's trochlea, if you remember, is a spool shaped. The ulna is a C shape. So basically it locks in and is able to move your arm up and down. Yeah, that's a hinge joint. Okay. Next, as I poke myself in my eye, pivot joint. Pivot joint means that you get a rotational movement. Okay, so think about when we went over in your vertebrae, cervical vertebrae number 1 and 2. Number 1, if you remember, is the atlas because it holds up your world. Underneath it is the axis. The atlas slides down on the odontoid process or the dens of the cervical vertebrae number 2, the axis, and it slides down on top of it like that. So what can you now do? You can turn your head left and right by pivoting the joint. That's how that works. That's a rotational motion, okay? Okay, so that would be that one. Let's see. Also, too, another good joint that does that, in order for you to take your hand to go from supine to prone, you understand the radius has to spin. The radius head is up here. So as my muscle here pulls, this bone spins. So as it pulls, it spins my radius so that therefore I can make my hand go over. Other muscles back here, called the supinator, is going to pull and pull back the other way. But it's going to spin and rotate. Okay. So that's a pivot joint. Ellipsoidal or condyloid joints. You know what a condyle is. Condyle is this bulbous end of a bone that usually goes into the fossa of another bone. So, perfect example, your knuckles. You have your fossa here, your condyloid, condyles right here. So when you make a fist, what you're looking at are condyloid joints, okay? Another one, if you remember, with the skull. The mandible has the mandibular condyle, and it fits into the mandibular fossa in the temporal bone. Therefore, it's a socket, and therefore you're able to move your jaw up and down. Okay. Plus the other examples I gave you. Now, let's see. Next one, easy one, saddle joint, only one in your body. This is what's going to separate you from all the other primates. You can do this. You got an opposable thumb. That's called a saddle joint. That means then, if you remember your wrist bones, the first wrist bone is the trapezium, okay? The trapezoid is the next one. The trapezium is going to fit with your, metacarpal number 1, and therefore it's almost like, when they sit together, it's almost like a rider sitting in a saddle. So think of like a guy sitting in a saddle that's kind of what it looks like, all right? That joint allows you to bring your thumb across the palm of your hand. Kind of a unique trait found out there in the animal kingdom. All right, so it's trapezium with the metacarpal. Okay, so last one. Woohoo, we're at the end. All right, so ball and socket, real simple. You got 2. The head of your femur goes into your acetabulum. The head of your humerus goes into your glenoid fossa. What does this do? The biggest range of motion you can do. You can take your arm and roll it around. You can do all sorts of things. Now, understand in this, there's going to be listings of some motions. You cannot neglect these motions, okay? So when I say the words or use the word abduct, abduction means to move from the central body. When you abduct a child, you're not taking it back to its parents. You're taking it away from the parents. So if I take my arm and abduct it, I'm moving it away from my central part. When I adduct, adduction, two D's, I bring it back in. So adduction means bring in, abduct means take away. Another one people screw up, you would never think this, is flexion and extension. When you flex a muscle or extend a muscle, think. If I take something and I want to flex my arm, I'm going to take it and I'll bring it up. What am I doing? I'm making the distance between two bones smaller. So when the angle between two bones becomes less, that's called flexion. When the angle between two bones becomes greater, that's called extension. Good? Other ones are pretty much self-explanatory. When you hear circumduction, that means, in a circle. When you say supinator, pronator, supine, prone, that type of thing. Trying to think of the other. Those are the major ones, okay? All right. Well, thank you for listening, and I hope this helped explain it.